basically it's a scratch and sniff. You're just going to scratch it a little bit, smell it, and then you're going to use this pen. You don't have to fill it perfectly. You can just even put an X on it. So go ahead and take your time to do that.
Can I use that to scratch? Or no?
Yeah, you can use that
Okay,
to scratch. Might have to go a little harder. Let's see if we can smell it. Can you? In this section of the exam, you're seeing me conduct a standardized form of testing called the smell identification test. The reason I'm doing this is because I really want to evaluate smell in more detail than just having the patient, pick up some scents I have in a vial. And this is mainly due to the fact that there's a family history of Parkinson's disease. So Sharon's mother has Parkinson's disease, and when you see a patient that's now in her 40s that is starting to have symptoms of chronic constipation and digestion issues that are getting worse, there's always the possibility of early Parkinsonian disease. And remember, this alpha-synuclein buildup that leads to Parkinson's disease starts in the gastrointestinal tract and the olfactory bulb before it progresses into the brain. So whenever I have patients where I suspect that they may have early Parkinson's disease, I'll do a more thorough evaluation of smell by doing this standardized UPSIT test that you see here. And her results were normal. So in this section of the exam, we see low blood pressure. Her seated blood pressure is 98/68. When she stands up, we do see improvement. Her blood pressure goes up to 103/73, but she does have hypotension and her perfusion index is very low. So when blood pressures are this low and perfusion indexes are this low, there's not enough shearing stress of the vascular endothelium to raise things like nitric oxide and vascular growth factor. So it really hinders recovery, really impacts endurance. And blood flow is not only important for circulation and getting nutrients to tissues like the brain and to the gut, but blood flow is an indication of just vascular health. So we're going to have to pay particular attention to her temperature differences between proximal and distal, her nail beds, and just general signs of poor circulation and where she's at. So this may be a critical part of her health that we need to address. Now, blood pressure this low can reduce the risk for stroke, but it can absolutely impair healthy function, healthy brain endurance, healthy tissue recovery. So we got to find out why her blood pressure is so low. So let's start with your legs here. So this is a bruise.
Yes.
Okay. And these look like you've got some bruises here. What are you just hitting? Or are you kickboxing?
Nope, just waking up, hitting the bed.
What's your side of bad balance? You said the side that's bad balance. This
side, yeah.
Is this side usually injured?
I don't pay attention.
You don't pay attention?
No.
Okay. And, all right.
I do know that what is happening now, though, is I'm getting really bad veining, especially in the summer months. They protrude all over, so I'm planning on stripping them.
Okay.
Is that okay?
It's just cosmetic.
Okay.
All right. And then, yeah, pretty good. Anything else happening with your skin?
Yeah, I have veins coming out of my fingers. That is bursting. I don't know if that makes any sense either.
So your refill time. It's pretty good. Nice and healthy pink. Okay. You get some. You hang into lots of things, it looks like.
Obviously.
Nails are also pretty banged up here. Let's take a look at your nails.
Yeah, they are. They are banged up. Here, like when you see this.
You get some lines, but you got some like white spots. Those are from impact. And you get some bruises. Your skin's really dry too.
Yeah.
Really dry skin.
Yeah.
Examination of her extremities and nail beds indicate that she has bruises and scratches that are just not healing on both legs. She also has nail beds that are all beat up that are not healing. So this could be one of the first expressions of having really bad circulation. She also complains of starting to get varicose veins that are cosmetic. And when you have someone who's got low blood pressure like this and a perfusion index that's so low, they're going to have a really, really hard time healing. And because of the poor perfusion index and low blood pressure, those circulating shearing forces that would normally activate endothelial nitric oxide synthase are not taking place. So now she's getting these varicose veins developed. So you can see that her vascular health is not the best, and we also have to suspect, with her history on the brain region localization form of balance issues and issues associated with the parietal lobe, that she could be really falling and bumping into things all the time. So we're potentially seeing a combination of someone who's constantly banging into things and the body's ability to not really heal that adequately. And the varicose veins is an indication that her vascular nitric oxide levels are starting to go down. Those aren't a concern. We don't see any patterns of chronic venous insufficiency where we see ulcers that aren't healing in the bottom of the foot, or swollen legs, or itchiness. She does have a little bit of blanching of the skin in her upper extremity, if you notice there. But there's definitely some indications here that there's some impairments in her general vascular health.
I'm sure my toes are much colder.
When we measure the surface temperature of her extremity, we can see that in her feet, her temperature is 75 degrees Fahrenheit, and her upper leg, it's 88 degrees. So there's a 13-degree difference. Now, anything more than 10 degrees is a sign of really poor circulation, and that's what we have here. Auscultation of her neck, carotid arteries, heart, lung are all normal. One of the key things I just want to point out is when you look at her respirations, when I'm asking her to breathe in and out, she's got really good chest expansion. And that's really important when you're looking for anyone that has early signs of Parkinson's disease. So one of the first things that'll happen is when they start to get into the rigidity phase is you'll see their chest not expand so well. So you see really poor spirometric readings, which we're going to check with her later. But you also see when you measure chest expansion, you don't get that full contracted muscle because of early signs of rigidity. But with her, we don't see any of those patterns, but just things that you should be aware of with her past medical history that we're looking at very carefully. Are you fasting right now?
No.
No? When's the last time you ate?
10?
10. Okay.
Why?
Because you don't have much bowel sounds.
I didn't take my calm last night. I didn't take my calm. I only took 3 magnesium pills, so it could be Rizzy.
Yeah. So when I'm doing the abdominal examination, it's pretty clear that her abdominal reflexes are intact. When I stroke her abdomen, her belly button moves to the side of stroking, and palpation's intact. But auscultation really shows that there was very little bowel activity. And this is why I asked her, when's the last time you ate? And it turns out she ate about a couple of hours ago. When someone eats a couple of hours ago, you should hear some degree of bowel activity happening. Now, once again, with the family history of her mother having Parkinson's disease, we're always worried about alpha-synucleinopathy buildups. And then in Parkinson's disease, we know it starts in the enteric nervous system. Now, we're going to definitely have to check her gag reflex really well, look at her palatine muscles, see if they contract. In early Parkinson's disease, you'll see changes only in gut motility before you see any changes that reflect brainstem function, which would be the gag reflex, and her palate contractures. So right now, we're very suspicious of what's happening with her enteric nervous system function because there's just very little sound of bowel activity. It's been a couple hours since she ate, and she has this history of having to take magnesium and supplements to have normal bowel movements because her bowel function herself is not able to do it, so she's got to soften her stools in order to get that food through her gut. So there's definitely something happening here, but seems to be a potential neurological component to it since her bowel sounds are so weak and almost non-existent. Any dizziness?
No.
On the way?
Maybe a little bit.
What did you notice?
Lightheadedness.
On the way up?
Yeah.
Okay. Let's do that again. Turn your head all the way to the right.
But very mild.
Any symptoms?
Yeah, like my blood is rushing to my head. That, yes.
Okay. Anything else?
No.
How about coming back?
A little bit.
A little bit? Mm-hmm. Dizzy?
A little bit.
Okay. Let's go this way here. Any symptoms?
No.
No?
It's similar feeling.
Well,
I
your
feel.
face is totally flushed. Just from that. You feel it?
I felt like my blood was rushing to my head.
Yeah. Okay. Just
And there's always this vein that pops out here whenever I feel flushed.
You're the only one in the world who notices it.
Really?
Yeah.
Really?
Yeah, I know. I probably drive you crazy, but you're probably the only one.
It's pretty pronounced. My veins are all frustrating me. They're all pronounced now.
With the Klein's test, you put the patient's head back into extension and rotation to put some shearing stress and occlusion stretch on the vertebral basilar arteries. And if a person has nystagmus or symptoms of vertigo in that extension rotation position, that's a positive test. Now, she does not have a positive Klein's test because in those stretching, shearing positions, there's no symptoms. She has symptoms when she comes back up. And this is really associated with some type of central vestibular disorder more likely than anything else. Now, we're going to have to do a Dix-Hall-Pike maneuver because she has some symptoms of dizziness to make sure it's not a peripheral vestibulopathy where you have an otolithic stone dislodged in the vestibular canal. But her symptoms of coming back up and then feeling disoriented and rotating are signs of a potential dysfunction, injury, degeneration, autoimmunity, or something happening to those cerebellar vestibular pathways. She also has an autonomic response where her skin just starts flushing just from those head positions. So we know there's some component here right away from the exam that her cerebellum and vestibular system are not normal. So anytime someone has a history of anxiety and has low body weight and she has a low body mass index, we're always concerned about a hyperactive thyroid. So I'm definitely palpating for any kind of thyroid nodules, any type of swelling that may be associated with any kind of Hashimoto's or Graves'. And her thyroid palpation is totally normal. So then I also do a very careful evaluation of her cervical lymph nodes. If you remember from her case history, she has had white blood cells historically low, so there's some degree of immune compromise. Now, during her lymph node examination, I could not find any swollen lymph nodes. Everything seemed okay with that. Perfect. So her spirometry readings are normal and her lung sounds are normal, so we can rule out any concerns for any pulmonary conditions impacting her chief complaints and her overall health. Perfect. And then you can see that the corneal reflex is normal. Touching her cornea with the tissue causes immediate blinking. So remember, this checks the V1 sensory pathway, and then the efferent output is cranial nerve 7, where you get that blink contraction response. And this is just checking the integrity of the upper brainstem. You just tell me where it is also.
No, right arm, left arm, right knee, left side knee, under my right foot.
I feel that?
No. Left toe. Left, same location.
Tell me as soon as you feel something.
I didn't feel nothing. Oh, right toe. Right toe again. Something, but I don't know. Left toe.
Okay, open your eyes.
Right foot.
Tell me if you notice a difference.
Yeah.
What do you notice?
I noticed this on my right foot, but not on my left foot.
Yeah, you don't feel as much on the left foot.
No.
Okay, this is your bad balance side.
Yeah.
Okay, we got something happening here. Let's see what else is going on. Okay, can you feel this?
Lightly.
Okay, let's compare it to this side. Is there a difference?
Actually, nothing.
You don't feel anything?
Very little. Now I feel it. Yeah.
Okay, let's try this side again.
Yeah, I feel it.
Okay.
Yeah.
Feel it?
Yeah.
Okay, close your eyes. Tell me as soon as you feel something.
Yeah, I felt it. A little bit. Yeah, a little bit there. A little bit. A little bit there.
You can see there's some issues with light touch perception in the left lower feet over the S1, maybe even a little bit overlap into the L5 dermatome. Now, if you remember, light touch is carried by both C fibers and by A delta fibers. So both of them contain receptor type fibers to take information up to the parietal lobe. There's got to be some significant degree of impairment to cause those to be impaired. Now, there's also some possibility anytime you see anything in the distal tissues that it's just related to poor circulation. So we're going to have to really look at our circulation on the bottom of our feet compared to the top of our foot, and also really get into dermatome testing with pinprick and vibration sense and temperature sensation to really see if we have any type of sensory perception issue that's either peripheral or even central based. You had a back injury?
Yeah.
What happened? You're not feeling stuff in your
Yeah.
dermatome.
Yeah, I had a back injury. I had MRIs done. There seems to be some issue in the lower back.
What does that mean? Do you know?
I don't know, because still to this day it hasn't been. We keep doing MRIs and they keep saying the vertebrae are like compressed in my lower back. But then I have a lot of lower back pain. Whenever I have bad pain, it runs through my left leg and it numbs my IT.
Yep.
And then that's kind of where we're at.
Okay, and this is the side of your worst balance, right?
Yeah, this tends to be the worst balance.
Okay. So you have like it looks like an S1 loss of sensation over your bottom of your feet.
Right.
S1 is a sacral nerve 1.
Is my what?
It's like sacral nerve 1.
Okay.
That's what S1 means. Do you feel that?
Yeah.
Same?
Yeah. Yeah. Yeah.
Same?
Mm-hmm. Yeah. No.
Nope.
Yeah. No.
No.
No. Yeah. A little bit now. Nothing. Nothing. Nothing.
Okay, let's just try. Sometimes the vibration dies off. Okay, so we'll get some pretty good vibration here.
No.
No?
No.
No?
A little bit.
A little bit. But it's different from here?
Now I feel it.
Yeah, it's much stronger now.
Yeah.
Do you feel that it's different than this?
Yeah.
Less here?
Yeah.
Okay. And do you feel that?
Yeah.
Is that different than here?
A little bit, yeah.
What do you notice?
Less on the toe.
Less on the toe.
Yeah. Now I feel it actually.
Same?
Pretty same, yeah. Yeah. No. No.
You don't feel it?
No. Now I feel it.
Less or more?
Much more.
Much more.
Very little.
Feel that?
Feel it. Yeah.
It's more of a polyneuropathy pattern. With vibration sense perception, we can see that she's having difficulty perceiving vibration perception in her distal tissues. And this is really common with very poor circulation. These large 1A diameter nerve fibers are highly vascularized and need healthy amounts of blood flow to function properly. But there are some indications that we may have some overlap, whether it's a past S1 nerve injury or injury to the parietal lobe. If it's going to be anywhere, it's going to be in the parasagittal area of the parietal lobe where you have a homunculus distribution of the lower feet. But there is some indications of sensory loss, which at the least concern would be just her poor circulation causing these, which is exactly how those patterns express because you see them on both feet. However, with the light touch sensation loss just on the light foot, we could have other possibilities. At this time, it's really unclear. We need to go through a thorough lower extremity evaluation to determine what's happening here. Tell me if you can feel this.
Yes. Yes. Yes.
Is it? Feel it?
I felt it.
Tell me if this is different than this.
Sorry, can you do that again?
Yeah, like just your foot relax.
No, the first one was more pronounced.
So the foot here is more pronounced
Yeah.
than here?
Yeah, no,
The same.
about the same.
At the bottom of your feet. You feel that?
Yeah.
You feel that?
Yeah.
You feel that?
Mm-hmm.
You feel that?
Mm-hmm. Yeah.
Okay. In this part of the examination, I'm using a pinwheel to evaluate pinprick sensation. And, when you look at a dermatome map and you see L4, L5, S1 dermatomes, you're going to see that those are not exact. And even if you look at different dermatome maps, you'll see different L4, L5, S1 distributions. And it's the same thing with humans. They all have different L4, L5, S1s. They're not exactly like you read in a textbook. However, checking the dorsum of the foot versus the toes versus the bum of the feet can at least give you some clues to where some of these patterns may exist. Now with her, we're not seeing any clear difference with any kind of dermatomes that are significant, and she can't perceive everything. And then I also check her distal area to her proximal area, and usually when people have circulation patterns, they don't feel it as much in their distal toes as they do, let's say, on top of their foot, but she has the opposite response, and now it's not clear that it may be a vascular scenario. So this is just some degree of sensory perception issues that are not clearly defined yet. So the possibility is still any kind of injury to the sciatic nerve from a past car accident to any kind of lesion all the way across that somatosensory pathway from the peripheral nerve all the way up to the parasagittal areas of the parietal cortex.
Yeah. 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 Mild though. Yeah. 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 Mild. Yeah. 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 Yeah.
When we do the monofilament test, we're basically taking this small nylon filament, push it against the foot, and making sure that it bends, and then asking the patient if they can perceive it. And this is a very good test to look for peripheral neuropathies. And with her, she does perceive sensation in both feet. However, she does report that with the left plantar surfaces of her foot, that they're not as recognizable when compared to other areas of her left foot. So once again, there appears to be some degree of sensory impairment in that left foot. Okay. And then try to walk on your heels. Come back. Come back on your heels. Okay. It's L5 and S1 muscle test. And it gets you moving. Having a patient toe walk and heel walk can be a really quick assessment of what's happening with the lower lumbar nerve roots. So when a person starts to toe walk and they're walking on their toes, they're primarily activating their gastrocnemius and soleus, and those are primarily innervated by S1. So you want to see if one side seems weaker when they're walking, if there's any kind of S1 nerve injury. And when people heel walk, they have to contract their tibialis anterior muscle in order to be able to heel walk, and that activates more of the L4, L5 nerve roots. I just want to see if there's any type of weakness. Now, it's pretty clear that she doesn't have any signs of any lower motor neuron disease. With lower motor neuron disease, you see atrophy, you see fasciculation. She doesn't have any of those patterns. But sometimes when there's been injury to a nerve root that's been chronic, you might have some remnant weaknesses that may be evident. So there's no active compression, but some past injury to nerve fibers, you can see some weakness. Now with her, when she toe walks and heel walks, we don't see any type of imbalances involving those walking procedures or any concern for those nerve roots having any kind of muscle injury. And we want to go a little bit deeper and actually test her individual L4, L5, S1 muscles, looking at myotomes to make sure that there is no past injury to these nerve roots from her past car accidents. How does you feel something say now?
Yeah. Very lightly. Yes. Yes. Very light. Yes. Yeah. 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 Yeah.
Okay. So I'm retesting her sensory perception with light touch right after she completed her heel walking and toe walking. Now, the reason I'm doing that is because if there's a vascular component, what I've had her do with these walking activities is to get blood flow and muscle contraction to those nerve roots that impact the lower feet. And when we retest her, we see that there is a little bit of change and a little bit of improvement, but she still has some impairments on that left foot. So it's very likely that there's a vascular component to this, especially with her temperature discriminations, and we're going to need to check that a little bit more. But there's also some type of injury anywhere from the peripheral nerve that's been chronic, that's not acute, not a lower motor neuron issue, but past injury to nerve root, or some type of injury involving the parietal cortex with the pattern we're seeing.
Same. 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 Yeah.
This way.
Mm-hmm. Mm-hmm. Yeah. Yeah. Yeah.
See?
Can you do this one again one more time? Sorry. Yeah.
See? Okay. Here I'm just testing dermatomes in V1, V2, V3, the upper cervical dermatomes, and the lower leg dermatomes that have really not been evaluated since we were focusing on the loss of sensation in her foot, and everything seems intact. Now, sometimes with parietal lobe injuries, you get distribution of pinprick sensation loss in areas greater than just the feet. You might have the entire side of the body, like a hemisensory pattern. She doesn't have any of those. She seems very localized just to the regions of her feet.
Mm-hmm.
Okay, hands ones like this. Tell me which one's colder, okay? This is number 1. This is number 2.
2.
This is number 1. This is number 2.
Can you do that again?
1
Mm-hmm.
and 2.
1.
Okay. You know what? I'm gonna check down here. Here's 1, and here's 2.
Oh,
Can't tell. Here's 1. Here's 2.
it's 2. Not by much.
Here's 1. Here's 2.
None.
Here's 1. Here's 2.
Same.
Same.
Mm-hmm.
Here's 1. Here's 2.
Maybe 2 a little bit.
Here's 1. Here's 2.
Maybe 2 a little bit.
A little bit different. How about up here? Here's number 1, and here's number 2. Which one's colder?
1.
Okay. Here's number 1. Here's number 2.
None. Maybe 2. Maybe 2.
Here's number 1. Here's number 2.
Neither.
With checking temperature discrimination between the cold side of the instrument and the warm side of the instrument, you can see that she's having some difficulty as we get more distal. So her inability to distinguish temperature as well as we go more distal is characteristic of poor blood flow and circulation. The pattern she has is not reflective of a nerve root or a sensory distribution of a nerve. So it's most likely a pattern associated with poor circulation. Yeah, I think it's just circulation with your feet. It's a 20-degree difference.
I feel it.
Yeah, it's not a neuropathy. I think we can hold off on the MRI. A little bit better here. Well, no. The toes, yeah. Right where you don't feel it is where the temperature's worse. Right at the big toe, for example.
That's why I want to put my socks
No wonder. Look at this, 80 degrees on top. Just from the top of your foot to the bottom. Oh my goodness, big difference. Okay. Surface temperature differences in her feet are clearly evident here. She has a significant difference in the top of her foot versus the bottom of her foot. So when you look at the top of her foot to the bottom of her feet, there's like a 10-degree difference in temperature. And now, overall, you can see a couple things. When you look at her temperature in her proximal tissue, like her thigh, it's like an 85.6. Then you go to the top of the foot, and it's like in the 80, low 80s, 82 degrees. And then you look at the bottom of her feet, and it's in the 69, 68 degrees. So this is clearly a entrapment. This is a tarsal tunnel entrapment. This is the only thing that can cause this. So when you remember your vasculature, the femoral artery is going to split into an anterior tibial artery and a posterior tibial artery. And the anterior tibial artery is then going to supply blood foot on top of the foot. And the posterior tibial artery is going to go through the tarsal tunnel, which is a ligamentous area between the medial malleolus and the calcaneus. And in that tunnel, if those ligaments are really, really tight, it can become entrapped. So now we know that part of her sensory loss may actually be a vascular entrapment syndrome of her feet, and appears to be happening significantly on that left foot, but also on the right. So we're going to go through further testing, but this is a very clear indication that there is a tarsal tunnel entrapment impacting that posterior tibial artery. This is not peripheral arterial disease. This is a entrapment, and this can also entrap some of the nerve fibers from the S1 nerve root to the feet as well. Push your foot all the way down, down, down. Keep it here. Hold your big toe down. You can't even hold your toe down. Curl your toes. Okay. Yeah. And bring your foot up here. Hold your foot here. Bring your foot all the way down. Yeah, hold it there. Can you hold it? That's your best, right? Okay. Yeah, there's not much in that position. Hold this here. Okay, hold your toe. Actually, I'm sorry, bring your foot up. Hold your toe here. Bring your foot all the way down. And hold it here. Yeah. There's an artery that goes down a tunnel right here. It's called the tarsal tunnel. So when we bring your foot all the way down, we entrap it. Is that tender in here?
A little bit, yes.
Yeah.
Yes. Yeah, I have
Sorry.
a lot of pain starting from here
Yes.
and going.
Right. Okay. So you can see when I do some myotome testing and test the strength of the flexor hallucis longus, the big toe, there's some major differences in her foot strength when she maximally plantar flexes versus her foot is up in a relaxed dorsiflexion. So when she maximally plantar flexes her foot down, that narrows the space in the tarsal tunnel, and you can get compression of branches of the tibial nerve and the posterior tibial artery branches. You can see when her foot's in total plantar flexion, she can't even contract her toe muscles. You can see that on both sides. And then when we go in there and palpate right over that tarsal tunnel syndrome, if that nerve is being compressed on, it's really, really sensitive. And with her, I just barely touched it, and she noticed a lot of pain there. Now, once that tarsal tunnel entrapment takes place, there's a lack of blood flow and also compression of some of those medial plantar muscles, so the feet can really start to ache, and that can really throw off biomechanics and also impact blood flow to some of the sensory fibers in her feet. So we have to keep this in mind when we do some evaluations of her balance, because there's some neurovascular entrapment of her feet that can probably throw off her balance, and we also have to consider this when we watch her gait analysis as well. Look straight ahead. So nice. Okay. With the pupil light reflex, you basically shine a light directly in front of the face and see if the light hits the eyes directly in the center of both pupils. And if the light is not equally placed on the same areas of both pupils, then you know that there is a deviation or eye muscle weakness. With her, you see a normal pupil light reflex. Her eyes are aligned. Okay, so you got a scalloped tongue. Get a stronger light. Okay, we'll do that. Go ahead and open. Just check out your tonsils. Your tonsils are okay. And say ah. And relax. And ah. Okay. And I'm just gonna. When you look at the examination of her mouth, you can see that first of all that her tongue is swollen. And when the tongue is swollen, it pushes against the teeth, you get those scallops. And that happens when there's a high degree of intestinal inflammation. So we see a scalloped tongue there. Now, you also can see that her mouth is very wet. You can see the light reflecting off, so she has good saliva production. That's a good sign that the vagal salivary nuclei are working very well. And then when you look at her gag reflex, she has a very good gag reflex and a very good palate contracture, and those are associated with kind of 9 and 10. Now, the family history of Parkinsonism, you're always worried about this alpha-synucleinopathy getting into the vagus nerve, but it actually starts in the gut. Now, if we look at the past findings of her auscultation of the abdomen, there was really no bowel sounds. So it's possible she may have a pattern of Parkinsonianism in the very early stages, where there could be some alpha-synucleinopathies impacting her enteric motor nerve plexus in her gut. But those alpha-synucleinopathy proteinopathies have not moved up the vagus, up into the vagal motor nuclei that would impact the palatine muscles and even aspects of parasympathetic activity like saliva production and the inferior salpatory nuclei. So we're not seeing any impact of the upper brain centers with digestion. However, it's still possible she may have an alpha-synucleinopathy impacting these mechanisms. Go and open your mouth. You can see with sinus illumination that there is very good lighting that you can see through with the maxillary sinuses and the frontal sinuses. So everything looks normal there. When I examine her retina with the ophthalmoscope, I can see that she has a healthy red reflex. Her retina is healthy and intact. Her macula is normal. Her optic disc and optic cup are healthy. And her arteries and veins look very healthy. There's no signs of any type of eye pathology. You can see that her pupil light responses are responsive directly and to consensual light. So everything's intact.
Relax, yeah.
Those feel nice. Ooh, that's tight. Yep. Does that hurt?
No.
It's just tight.
I'm used, this to me today is like good day. I don't have pain.
So evaluation of muscle tone is really important because she has a family history of Parkinson's disease. With Parkinson's disease, you're really looking for what's called lead pipe rigidity or knife clasp rigidity. She doesn't have any of those in the upper or lower extremity, but her left lower limb is extremely tight. It's really more spastic. And those are what you see with injuries to the motor cortex. So sometimes it's just tightness because of abnormal posture and compensations for other injuries. And sometimes it's really related to a brain-related mechanism. So we have to see other types of brain-related upper motor neuron patterns or signs to assume that that could be from brain-associated injury. If it is, it's going to involve the contralateral motor strip right by the superior sagittal area if we're seeing expressions of it in her lower limb. This is also the same area that we would suspect from part of her sensory abnormality findings that weren't due to her tarsal tunnel syndrome. Let that relax. Okay. So with her deep tendon reflex, you can see that she has hyperreflexia on that left L5 DTR. And she has hyporeflexia of the right DTR. Now this is actually due to a phenomenon in the spinal cord called Renshaw cells. So if you have an overactive deep tendon reflex, you have suppressive impacts on the opposite side. So it's not like that the right side has a lower motor neuron pattern and the left side has upper motor neuron pattern. With significant degree of spasticity of the corticospinal tract of the anterior horn involved with that left side, you're going to have some suppression with Renshaw cells on the opposite side. So that's why you're seeing that right DTR that's abnormal. At the end of the day, now that we look at her rigidity, and not her rigidity, but her tightness of her hamstrings when we stretch her legs, and we see hyperreflexia, we're starting to think that she may have some injury to that cortical spinal area and that premotor area. This now involves motor functions. Now, before we found sensory disturbances, we found some sensory loss associated with the contralateral parietal lobe. We saw some blood flow and circulation issues involving that left limb, and then we also found a peripheral neuropathy of that tarsal tunnel syndrome with that neurovascular bundle entrapment of her feet. So she's got a lot of different things happening here. And this is probably why no one's ever diagnosed her properly, and she's kind of confused why she constantly has leg pain and back pain and all the other things that she has chronic symptoms with. It's probably because of lack of a thorough exam and interpretation. But now we're very much seeing signs of an upper motor neuron pattern in addition to everything else. So here I'm checking for upper motor neurons, looking at the lower extremities. So I do the classical Babinski, stroke her foot, then I stroke the side of her foot, classical Oppenheim, then I squeeze her calf muscle, the Gordon reflex, and any type of toe extension sign would be a sign of an upper motor neuron. So with these tests, we don't see anything that's abnormal. So here we're doing upper motor neuron testing using the upper extremities, and we're flicking the inside of the finger and the outside of the finger and looking for if the fingers and thumbs come together, if we see any abnormal muscle contractions. So we're doing Hoffman's and Trotner's sign. Now you can see when we flick the inside of her fingers that we see that pinky start to contract. Even though it's not the classical finger and thumb coming together, it's still a positive test. So you have to remember that when you look at the descending pathways of the motor system, there's also a homunculus. So depending on which fibers get injured, you can have different expressions of upper motor neuron signs in various fingers. So what we're seeing here is with her left hand that she has a positive upper motor neuron sign. So we suspect that there has to be some type of upper motor neuron lesion somewhere in the cervical cord or up into the cortical spinal projections through the anterior limb all the way up into that motor strip, somewhere along that pathway. It's starting to look more and more like that this is a brain injury. There could be some injury to the white matter of the cord, but this is not lower motor neuron. This is not a peripheral nerve injury. There's this overlap with the findings that there's something happening in the brain. Now, we know she's got vascular compromise impacting her sensory perception. We know how she has some sensory loss associated with the parietal lobe. We know she's got some tarsal tunnel syndrome in her feet. And it looks like we definitely have some indications of a right brain injury because we're seeing these upper motor neuron signs in the left. We're seeing increased DTR reflex on that left leg as well. And when you see like the upper extremity and lower extremity not necessarily correspond, you're more than likely dealing with a brain injury than you are with something happening in the cord. Tell me about your neck pain.
I've had it for a long time. They say from the time of my car accident, but I mean, I have it sometimes. It's something I always have. I live with it. Sometimes worse than others.
Okay, what's that? It's worse. What do you notice?
Sometimes when I'm like stressed.
Yeah.
Or I've been like, I try very much to keep my posture properly, but I generally have pain here, and then it goes here, and then it's my TMJ, and like that.
Does it ever go down to your leg when your neck's tight?
It never goes down like that.
When your neck's tight, you never feel it in your legs?
I feel it in my legs, but I never put two and two together. I mean, I generally do have IT pain, and especially if I've exercised and did something wrong.
Okay.
Not even wrong, just walk too much.
Now, when you hear a history of pain, what you're really seeing is the clinical expression of someone who's got loss of proper muscle integration. So we already know just from some early signs when we did the declines test, when we brought her head up, she started to have motion and movement disorders. You see that with vestibular cerebellar injuries or disease or dysfunction of some kind. We're starting to see some signs of upper motor neuron patterns and probably injury to the motor cortex. Now, the motor cortex and cerebellum are very much involved with maintaining proper postural stability and muscle tone. So when she says her pain happens when she exercises or moves, this is a strong indication that her brain doesn't know where her muscles and limbs are in space, and she's probably having spasticity taking place anytime she has any kind of physical activity or exercise. These aren't due to like a misaligned spine or, certainly after you get muscle tone imbalances, you can have, joint misalignments or something. We're also not hearing her say that she has something that's associated with neuropathic pain, like that burning pain that people sometimes discuss when they have neuropathic pain, like nerve injury, pins and needles, temperature changes, sensations. That would happen if there was a peripheral nerve injury. So it seems like she's really discussing like metabolic deep muscle pain after she works out and exercise, and that can absolutely happen when you have brain injuries that impact muscle integration and muscle tone and posture, which is what we're seeing with her. So I think a big part of her pain syndromes, including her inability to heal and recover from her poor circulation and blood flow and her tarsal tunnel syndrome, and most likely some injury to the parietal lobe and frontal lobe, and probably even the cerebellum, as we'll see as we do other testing, that she's got a whole mixture of things that are happening here. Now, we're still looking at the chief complaint. Her chief complaint is GI issues and anxiety and other types of patterns, but these things may help identify some underlying mechanisms that may be impacting those chief complaints as well. Hold this here like that. Hold your fingers. Hold my fingers in between yours. Don't let me pull out. Bring your fingers back. Hold these out here. Don't let me push in. Just like this. Out like that. There you go. Hold my fingers in. Don't let me pull. Okay. Hold this like this. Hold this like that. There you go. Hold these fingers in like this. This one back. Extensors. Okay. No, these are all good. So with testing of her cervical myotomes, C5, C6, C7, T1, everything's intact left and right. And this is just a further test to rule out any type of radiculopathy, which we're not seeing any findings of. The jaw stretch reflex is intact. This is testing V1 motor loops involving the upper brainstem. You feel that shake? Mm-hmm. Mm-hmm.
Is that not supposed to be there? Oh, it doesn't. It's not in here. This side doesn't have the shake. This side, yeah.
That's clonus. So you can see with a quick stretch of her left leg that we see 4 to 6 beats of clonus. Clonus occurs when there's an upper motor neuron lesion. So again, any type of lesion from the anterior horn on the left side all the way up the spinal cord on the ipsilateral side to the pyramidal desiccations in the lower pontine area, which then cross the contralateral side up the anterior limb into the cortical spinal tract. There could be any type of lesion. Most likely, based on other patterns, we have some type of injury to the right motor strip.
I know this because of my mom.
Yeah. Do you ever practice this?
No, I've seen her do it 100 times.
Okay. Go like this as fast as you can. All the way open, all the way close. Fast, 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 fast. So that's pretty good. And the other side?
This is harder.
This is harder?
Mm-hmm.
Yeah. So the chief complaint of chronic gastrointestinal motility issues in a family history of Parkinsonism, we're always worried about early onset Parkinson's disease that can happen with people in her age group, like in their early 40s to late mid-40s. You can have early presentation of Parkinsonism. Now with that, one of the earliest findings you'll see is hypokinesia, slowness of movement. So with her rapid finger and foot tapping, we can see that there is no abnormal patterns, that they're equal from left to right, and that there's no slowness of movement. So far, you can see there's no clinical signs of any early Parkinsonian patterns, except that she just has really poor gut motility, which may be where early Parkinson's disease starts. We still haven't identified the underlying culprit of her gastrointestinal issues from the exam, but Parkinsonism is still possible with anyone with a family history and chronic GI issues in the very early stages, despite having no other clinical findings. We just don't have enough criteria to diagnose her with Parkinsonism with her current findings. And then below your cheeks, and then stick out your tongue. That's this. We'll show you. This is a scallop tongue. I'll take a picture of it. Like your tongue is pushing against your teeth, so it's swollen. So you get those scallops there. And then relax here. I'm just gonna tap. Just gonna check. Okay.
Why would I have swollen tongue?
Well, your gut's inflamed. When your gut's inflamed, you get a swollen tongue. Because your whole esophagus all the way up gets swollen. And then
So when I'm inflamed, the whole thing is inflamed.
Here I'm just quickly going through and checking facial muscle tone, rooting reflex, Myerson sign, hypothenia percussion, and to be honest, I'm forgetting that we're recording a case. In a normal exam, I'd be going through everything pretty rapidly, pretty quickly, interpreting things. So I'm kind of combining all these things in this section because I didn't slow it down for the exam. But you can see they were all intact and normal. The cover test is totally normal. There's no patterns of esophoria or exophoria, so there's no abnormal deviations of the eyes or any types of eye muscle weaknesses that may be associated with any upper brainstem dysfunctions. Try not to move your head at all. Okay, try to stay on target. I think you're jumping at it. Keep your eye on it, and I'll hold your eyelids open and bring it towards your nose. Perfect. Now, I want you to look fast as you can, back and forth between these two fingers. Fast, fast, fast. Is that hard?
Yeah.
Yeah. Harder going to the right?
Huh?
Is it harder going this way? Can you tell?
Yeah.
Yeah.
This is hard too.
Yeah. So these are all frontal lobe eye movements. So in this part of the examination, I have her do visual tracking and quick eye targeting, which are called saccades. And when we do visual tracking, she can track the pen accurately, but what you'll see throughout the exam is her eyes start to tear. You can progressively see her eyes tear, even get a little bit red as we're doing this. These are clear indications of her brain just fatiguing from these simple types of tests. Now, when you watch her tracking at the very end of movements, especially on diagonal planes, you can see that there's a little bit of fatigue and flutter towards the end of movement. Then when we have her do saccades, which are quick targeting movements, she has a really hard time generating enough speed and accuracy when she does those, but the key thing is her brain fatigues when we do these. Now, eye movements are generated by different regions of the brain, but the frontal eye fields play a role in all types of volitional eye movements, meaning that the patient is conscious of where those eyes are moving. And once again, we're seeing some indications that her frontal lobe may be involved. Now, the interesting thing is these frontal eye fields are on the left, and 97% of people, 3% of people, they're on the right side. Now, with her clinical findings of clonus and positive trauma sign and hyperreflexia are all on the left limb, which indicate a right-sided brain injury. So we're not really sure why we're having patterns on both sides. It could be she's in that 3% where her frontal eye field activity is on the right side. There's no way to know that other than just to, evaluate what you have and see how she responds with different types of treatment. But the clear thing from this section is how simple, trivial movements just completely fatigue her brain. Now we want to see if this fatigue now leads to her symptoms of anxiety, which is a chief complaint. A lot of times when the brain fatigues and a person can't handle any more input, they get very, very sensitive to sound, they get very sensitive to light, they get very sensitive to any kind of input, and they get irritability and anxiety from those patterns. I think you got pretty banged up in a car accident. Tell us about your car accident.
So I was in 3 car accidents. Her first one, but I was young. Like my first car accident, I was 18, and I was at a red light, and I got hit by a driver that didn't see the light. So I got hit 80 kilometers an hour from the back. Okay. Then my next car accident.
Now, did you have any injury after that?
Not. And then I went to physiotherapy, but for the short time.
For neck pain back then?
Just because they told me I had to.
You didn't want, okay. So what's the next one?
Then my back pain started to come in my early 20s. And then the next one was a motorcycle accident. I was the driver of a motorcycle coming home from university. and a gentleman in front of me who was sadly mute, he went from like 70 kilometers to 0, and I was behind him, and there was traffic. So traffic meaning there's cars going, so I came and tried to get out of, but then I hit the side of the car and I went up, came back down again. Was unconscious until somebody started talking to me, and then they took me to the hospital. I was admitted and let out same day.
Same day. But you did lose consciousness.
Yeah.
Do you have any idea for how long?
All I remember is a girl from my school who was driving home too, but in her car. I heard her voice talking to me, Shiva, 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 and that's when I woke up.
Okay. And what about
and
symptoms afterwards? Did you have any focus, attention, concentration issues?
Do you know, it's funny because I didn't see any impact immediately, and then it started with back pain.
Okay.
Then it just
progressed.
progressed.
After the second one, or after the third one?
I think, they all happened in a very short amount of time. It was like from like 17, 18 to like 19, 20, all three happened. And then the third one, I was just sandwiched between, I was trying to make a left behind somebody who was also making a left, and then somebody came from the back and hit me. But I believe I can't pinpoint which one started it, but I knew that then I started to have back pain. And then that's when I started to tried physiotherapy, then did this. Now the only thing that helps me when I spasm, and 3 times I've taken out my back while it was like exercising, nothing crazy. And then I just was done. And then for a week or 10 days, I couldn't get out of bed. And then there's one place called Meditech. It's a laser.
Yeah.
That's my salvation. I still go.
Okay.
I go regularly. Oh, tremendously. I would have been chronically addicted to painkillers.
Okay. And they just laser your lower back?
Laser my lower back, my IT band, and then sometimes my upper back. Because now what's happened is that the pain is moving now into my mid back, which it never was.
So when you listen to the history of her car accidents, you can really see that there was one incident where she had lost consciousness. If you lose consciousness, you've had significant injury to your brain where you can't activate your reticular activating system. And there's no question that that type of injury is going to cause some neuroglia priming. And all the principles we talked about in the neuroinflammation course could really be expressing themselves here. So this is also why this was the first course I taught for the Cardiology Institute, because this is a key mechanism that happens with many chronic patients that gets overlooked. Now, her back pain and her neck pain, she didn't happen after injury to her back and neck specifically. It happened after she had trauma and had a brain injury, and it's impacting her muscle tone. So once she starts to move and do any kind of physical activity, if she does too much, if she exceeds her brain's metabolic activity, her muscles get tighten up. She basically gets a form of exercise-induced dystonia and gets those inflammatory responses happening in her IT band and her joints and her ligaments because the muscle tone's abnormal, and she probably put strain on those ligaments, and lasers seem to help. Now, patients like her with her history typically go and get their acute care for wherever and ever. They become like the mystery patient, why treatments don't hold, why they have to constantly get treatments over and over again, and they can spend tens and thousands of dollars on different types of therapies to get out of pain, thinking that they have an ongoing neck and spine issue, but in fact it's really related to brain-based muscle tone patterns from lack of activity and integration, most likely with her pattern so far, from her motor strip and her cerebellum. Perfect. Look over here. Look straight ahead, right in front of you.
Oh, it's hard to do that.
Yeah, keep your eyes straight ahead. Okay. What I'm doing here is just looking at her eye movements using an optokinetic tape. An optokinetic tape is just basically red and white strips, and when you move it across, you have some visual tracking of the color, the red, until the next one comes, and then you look at the next one into the next one. And those quick eye movements are called saccades, and that tracking are called pursuits. And different regions of the brain are involved. The parietal insular vestibular cortex is involved with pursuit movement. That's on the right side of the brain, and the frontal eye fields push the eyes to catch the next saccade. Now the point is not to get to the deep neurology of that, but the point is she's fatiguing. You can just see her total facial muscle fatigue just after a few strips of that, and she said this is really hard to do. It's really a very simple, easy test. It's a normal reflex. Your eyes just move when you have that tape in front of you. So with her, it's causing difficulty to form that task, and she noticed that she's having some issues just looking at this tape, and if you look at her facial tone, you can see her brain fatiguing. These are all signs of brain inflammation, mitochondrial uncoupling, all the things we talk about in the neuroinflammation course, all the things that we talk about in the pain and fatigue course, really right in front of you in a clinical setting. As fast as you can. And the other side. Okay. So here we're doing finger-to-finger testing, looking for dyspraxia. Dyspraxia is the inability to coordinate movements and sequencing, and she's able to do that. And these functions are involved with the premotor areas of the brain, and they seem to be intact.
I see blurry right now when you go to the side.
Okay, 1 second. Yeah, your eyes are fatiguing. They just bounce. You feel them bounce?
Yeah.
That's fatigue. Not as bad on this side, right?
Mm.
Well, let's have you look. Keep your eye.
They feel both sides.
Yeah, it's really visible here on this side. What I'm doing here is I'm just turning her head and having her keep her eyes volitionally looking at me. And you can see when we turn her head, if you look very carefully, her eyes are bouncing back and forth. It looks like nystagmus, but it's not nystagmus. True nystagmus has a slow phase and a fast phase. This is just fatigue of her eyes. This is just another expression since she's volitionally looking at me while her head is turned. That's not necessarily a vestibulo-ocular reflex anymore. That's really a volitional frontal eye field activity. So we can see that she's having some fatigue issues. Then I do what's called the Helmagi head thrust, where I just move her head quickly back and forth and see if her eyes can stop quickly, and they do. In any case, those are the key findings that we see with these testing. It indicates really fatigue of the brain. Come all the way back. There we go. Eyes open. Perfect. Come forward. Any dizziness? Just lightheadedness?
No, yeah, just lightheaded.
Okay. Any symptoms?
No.
Okay.
Oh, this side I became dizzy a little bit.
On the way up.
Yeah.
And the most common cause of dizziness is a dislodged crystal into the posterior canal. And the Dix-Hallpike maneuver will provoke that crystal position. And the key thing with doing this test is once a person leans back, you have them look straight ahead with their eyes open, wearing those Frenzel goggles. Those Frenzel goggles prevent them from fixating on a target. And if there actually is this peripheral vestibular disorder where there's crystals dislodge here, this BPPV pattern, benign perioxymal positional vertigo pattern, you'll actually see nystagmus, and you see like a diagonal upbeat nystagmus with that posterior canal involved. She doesn't have that. We do it both sides. She doesn't have that. When we bring her back up, she reports of dizziness. That is not a positive Dix-Hallpike response. Positive Dix-Hallpike response is clear vestibular nystagmus when the head is positioned that way, not dizziness when you bring a person back up. When you bring a person back up and they have dizziness, that is not a peripheral vestibulopathy. That's a central-based pattern. Her brain can't figure out where she is in space. It's not due to activation of a crystal in her inner ear. As a matter of fact, continuing to do this type of repositioning that people do for otolithic crystal dislodgements will actually make a person really, really sick and fatigued the next day. So she does report dizziness, so we will repeat the test and just make sure that is actually there, and then we can try to determine what type of central vestibulopathy that she may have. Which way did you feel like you were spinning? Clockwise, counterclockwise?
I didn't pay attention to that. I was just like, okay, just get yourself together, as I was telling myself, okay, just because I felt quite like a bit of a spin.
Okay, let's try again.
Oh.
See?
Oh. Again, I have to have that feeling.
Let's keep you there for a sec. Come all the way up. Tell me if you start to spin again.
Yeah.
You're going to the left?
Yeah.
Okay. So we have to repeat the Dix-Hallpike maneuver to figure out when she comes up and feels dizziness, if there's a certain area or position or movement that she's having that can help us figure out what type of pattern is occurring. So when we have her come back up from the Dix-Hallpike maneuver, she once again does not have a positive Dix-Hallpike maneuver because she doesn't have position-induced nystagmus. But when she sits back up, she feels like she's spinning, and we go into further questioning. She has like a sensation that she's falling to the left or spinning counterclockwise. So that lets us know that she has a left vestibulocerebellum injury that's involved there. Or sometimes when you get a right brain injury, you lose direct input to that vestibular system on the contralateral side. But in any case, people fall to the same side of their injury. People feel like they're spinning and falling towards the side of their injury. So with her, we know that there's a left-based pattern. Twitching here a lot. You notice that?
Do I have a what?
Twitching of your eyes.
Yeah. I'm tired now,
Yeah.
I think, and it's twitching, yeah.
Did you even not much sleep last night?
No.
Is it always that side or is it both sides?
No, it could be. Sometimes a lid here, sometimes, yeah. And I think now my eyes strain too.
Your eyes are strained?
Yeah.
From the eye movements?
Yeah, I think so.
Yeah. Were they hard for you?
Yeah.
The ones were, which ones in particular? The ones with the tape, or the ones where you were going back and forth quickly, or the ones that you were tracking?
I think the ones that were going back and forth quickly were not difficult, but I think they were tiresome.
Yep, so those are specific for the frontal lobe. Those
Right.
activate the frontal eye field.
Right.
And they were really slow with you, and you wouldn't
Yeah.
target. And it was
Yeah.
actually much worse going to the right.
Right.
And that may have cooked your brain already, because
Yeah.
it's so specific for that region.
Yeah, I think it cooked it.
But I don't think it's related to neurodegeneration. I think you may have injured it from one of those accidents or something. Most likely, they happen from when you lose consciousness. That's when you get. If you lose consciousness, that means you have to have severe enough brain injury. You don't lose consciousness without a significant trauma to the brain. So during the exam, I can see that her eye muscles are twitching. She looks exhausted. She looks completely fatigued, and this is what you see when you have a person that has poor brain endurance and mitochondria in the brain that are not working. So just tracking, a person's finger or thumb a few times and looking to the left and right a few times shouldn't cause someone to be completely exhausted. Unless it's activating an area of the brain where there is impaired mitochondria, most likely from injury in prime glial cells and neuroinflammation in that area there. So we're seeing these clinical presentations very clearly in front of us. If you take a look at some of her facial tone and her energy and vitality, from the beginning of the exam till now, you can see a huge difference. And even just before we did the visual tracking till now, you can see a huge difference. These are things you want to pick up as a clinician. You want to see if patients fatigue directly in front of you. If you see that, you're always looking for past brain injuries or any type of mechanisms that impact brain endurance and mitochondrial function.
I'm a fast walker.
Is that how you normally walk?
I'm a fast walker.
Because your feet are cold? Is that why?
Yeah, it could be. But if you walked beside me, you would need to walk fast.
Okay.
As my husband says, where are we going?
Okay, when you come back this time, do the alphabet, but every other letter.
Oh, I'm not so good with my alphabet now. Okay. A, C, E, G, I, K, N, P, R, U,
Okay.
W.
First impression when you look at her gait is that there's something wrong. And there's actually multiple things that are involved here. First of all, when you see her walk, it looks like she's walking like she's in pain. It looks like she's needing to get some movement or circulation happening. But in any case, there's a couple specific things that I want to point out. First of all, you can see she's not really having good push off with her foot. So remember that she had a tarsal tunnel syndrome, and her tarsal tunnel syndrome had this very clear flexor hallucis longus muscle weakness, and that happens with entrapment of getting plantar nerves innervated to the muscles of the feet. She also has a clear slapping of her feet when she's walking. You'll see that slapping the feet anytime someone has any kind of sensory dysfunction where they can't feel the ground as well. You'll see those slaps. You may even hear slaps. Anytime you see slaps of the foot or just slamming the feet down is many times due to having decreased sensory input to the feet, which we know that she has. She also has lots of deviation left to right, and that's most likely due to some degree of postural instability. Well, there's some tests of stability, but with her symptoms of rotational vertigo from coming back from a supine position in the declines tested in the Dix-Hallpike maneuver, it's very clear she's got some cerebellar dysfunctions, which we'll see when we do some tests of stability. And then we have her double task. When you double task, you're really activating areas of multiple centers of the brain, and immediately we see that she stops having arm swing. And lack of arm swing with double tasking is a strong indication of lack of frontal lobe function, which we know is there from multiple signs from the exam so far, and symptoms on the brain region localization form. Eyes open. Just stay there. Okay, go ahead and close your eyes. Eyes open. Put one foot in front of the other. Directly in front of the other, like you're on a balance beam. Eyes open first.
Oh.
Is that hard? Mm. This has your left foot back, which means most of the weight's on your left foot. And that's not that easy for you. Okay. Try with your right foot in the back, left foot forward. And that's easier for you.
Yeah.
Yeah. Okay, just stand feet together. Mm. Just stand on your left foot. Lots of instability there. Lots of shaking. Stand on your right foot.
Also not so good now. Actually, not good at all.
Not as good as... No, that's both. Now, is it harder for you on one side versus the other?
Now both of them are hard. This one actually feels better than this one. This one just is bad.
Okay. Go ahead now, close your eyes. Put one foot in front of the other. Doesn't matter which one first. Just try to stay there. Other side. Okay, feet together. So it's pretty clear when we do a Romberg's test and then tandem Romberg's test that she has instability. And we know that she also has some sensory impairments in the bottom of her feet, especially her left foot, but she actually has a bilateral tarsal tunnel syndrome. So that could be playing some role with her instability. But there's also very much clinical indications for cerebellum dysfunction, which is involved with integrating vestibular inputs and proprioceptive inputs from the feet to the brain to help stabilize muscles of the intrinsic spinal muscles and postural muscles to keep stability. So it probably has a little bit of both. Now the cerebellar pattern is going to become more clear when her eyes are closed and she can't get that visual input. So it's a greater challenge in that. Now, in a real clinical setting where you have more time, you could basically treat her tarsal tunnel syndrome. You would strip all her gastroc muscles and calf muscles, adjust your feet, and really, as you get rid of the muscles that pull on that tarsal tunnel ligament, you can open up the space, and if her temperature sensation in her feet improved, and you can see her muscle strength improve and plantar flexion, and then you check her balance, you could get some indication of what degree of her balance was due to the tarsal tunnel syndrome once you remove that entrapment. And then didn't figure out the rest of that might be centrally based. Now with her, we have a combination of both things happening, but the greater expression of her brain patterns are clear when she closes her eyes. Okay, and then stay here, feet together, and then do the same thing, eyes closed. That's pretty good. You can do it. Okay. So tandem walking, you can see significant instability. I thought it'd be much worse. She was able to compensate pretty well, and despite having sensory impairments in her feet and bilateral tarsal tunnel syndromes and some patterns of vestibular disorders, central vestibular disorders, she was able to actually walk across. But it's still a positive test. She still has moderate ataxia while performing tandem walking. Fast, 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 fast. Okay. When you look at her repeated supination pronation, you can see her speed is very good, so further indicates she doesn't have any patterns of hypokinesia, slowness you see with the early Parkinsonian patterns. And then you can see that for the most part they're normal. If you want to be extra critical, you can say there's some degree of dysdiadochokinesia is very mild on the left side, but for the most part they look pretty good. Only this tip. There you go. And then only this tip. Okay, now keep all your fingers open so I can touch different fingertips.
What do you want me to do?
Touch your nose.
Oh.
Okay, a little slower.
Missed that one.
Okay. With the finger to nose test, you see a couple things that are abnormal. First of all, she has pass pointing. She misses her target, which is her nose. Those are things you see with injury or dysfunction in the parietal lobe. She does that repeatedly, so we know there's some degree of inability for her brain to recognize where her limbs are in relation to her nose. Now, we also see, if you look right when she touches her nose, you'll see her hand have a little tremor. That's a termination tremor. You see that with cerebellar injury. We have some pretty significant indications that her brain is injured from these examination findings. Okay. And do it a little bit harder.
Oh.
That's good. It's a pull test. It's really important for Parkinson's.
Okay.
Parkinsonism, you're fine. Okay. Put one foot in front of the other. That's fine. Use that one. And I just want to see if your balance changes if we turn your head to the left. It's the side you were spinning towards. Is that worse?
Same.
Same. Go this way. Same.
Same.
Okay. All right. The pull test is a test that's used to look for postural stability. When many people develop Parkinson's disease, they lose their postural reflexes and they feel like they're falling backward and they bend forward. They get that hunched posturing when they walk. And that's not a dysfunction of their spine, but really a loss of postural reflexes neurologically. And one of the earliest ways to find that is with a pull test. Now remember, once again, the family history of Parkinson's disease, we're looking for any types of early clinical presentations of Parkinsonism. She doesn't have any type of rigidity. We know that she doesn't have any types of hypokinesia. She doesn't have Parkinsonian tremor. She has termination tremor when she touches her nose, but that's not Parkinsonian tremor. And her pull test is normal. So an abnormal pull test is when you have a person maintain their balance. When you give them a little tug, they'll fall back with more than 3 steps. Usually they'll shuffle back with multiple steps because they have lost that postural reflex. So with her, we're not seeing any indications of Parkinsonian pattern. The only thing that we're concerned with is we really have chronic constipation and constant need for her to use stool softeners and things like magnesium to have bowel movements, and abdominal auscultation clearly indicates she doesn't have healthy bowel sounds and bowel motor activity occurring there. Look to the left. Hold it there for 6 seconds. 1, 2, 3, 4. Feeling bouncing? 5,
Just
6.
tired.
Yeah, see how tired they get? That's all frontal eye field. They're just fatiguing on you. Just relax your eyes. Does that make you exhausted?
Yes.
Okay. And then look to the opposite side for 6 seconds. 1, 2, 3, 4, 5, 6. Stop. Is that also the same thing?
Yeah.
Yeah?
A little bit, yeah.
How bad is it? Do you need to like close your eyes? Do you need a nap? Do you feel like you should take a... And now your pupil size, by the way, has changed.
I feel like a little tired, yeah.
Your eyes just dilated and got larger on the right. It's just from that fatigue. Here you can see I have the patient with these goggles on. That's just so you can record and see the eyes. You don't necessarily need these goggles. But the point is, I just have her do lateral gaze. So lateral gaze to the left and lateral gaze to the right. And she does it for 6 seconds. And one of the things you'll see is her eye starts bouncing back and forth. It's almost like if someone is holding a heavy dumbbell and it keeps dropping and it keeps dropping because it's too heavy for them to have the strength for it. That's what you're seeing with her eyes, that little bounces. Again, those are not nystagmus. Those are just fatigue patterns. And she reports she gets really exhausted doing that. And also, if you really look carefully, you'll see that there's increased tearing in that 6 seconds. Right about 4 to 5 seconds, you'll see that there's more watering in the eyes, and that happens when the brain's fatigued. So if you get a chance, just look to the left for 6 seconds, look to the right for 6 seconds, and see if it totally shuts you down. And you can see for her, it's a big problem. So this is, again, an indication of injury to the frontal lobes. It's actually pretty clear that it's both of them, and meaning the left and right. And she's got some significant patterns of mitochondrial impairment. Now we have to figure out why her mitochondria are not functioning, why she's not recovering, is a big part of the treatment protocol. But patterns of having like really low blood pressure, really low perfusion, is going to be a key factor of getting blood flow to the brain. When you look at her body mass index and waist-hip ratio, she's definitely underweight. She's got really low white blood cells. These are all factors that we have to consider what's happening with her brain, her mitochondria, and overall endurance. It's all the way, 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 all the way. Perfect. Okay, then relax. Here I'm just testing visual confrontation. You don't need goggles to do that. You can just see it very clear in the goggles. Her eyes do converge and her pupils do constrict. So she has normal confrontation. And then I'm going to see if we can create any kind of movement or motion with you with your head, with shaking your head. So you're going to shake your head for 10 seconds. Ready? 1, just straight across, all the way as far as you can to the left, all the way to the right. 1, 2, go a little faster. 3, a little faster. 4, 5, 6, 7, 8, 9, 10, and then look straight ahead. Keep your eyes open. And there we go. We got some nystagmus happening. You're spinning?
Yeah.
Yep. Which way?
This way.
Yep, to the left. That's the side of your fast beat nystagmus. We can show this to you in a little bit. All right. You okay? You feel like you're moving still, right?
Yeah. I feel like I'm still moving a little bit, yeah.
Yep. The same movement that when you got up from that goggle I had you lean back on, you said you were going to the left. So that's what we're seeing here. We can see your eyes move in a certain direction. It lets us know you're spinning to the left. Okay, eyes open here. Just relax. Focus on something on the screen. It should help you calm down. Are you okay?
Yeah. I feel like I'm still spinning.
Still feel like you're spinning? Go ahead and stare at your thumb, and that should make it go away. Is that helping?
Yeah.
Okay, just keep
staring
until it goes away. So whenever you get dizzy, just stare at your thumb. Back, eyes open, down, up, side, side. Okay. Here what we're doing is a head shake test. And a head shake test has the patient move their head to the left, move their head to the right. So they're activating the left and right vestibular apparatus. And after 10 seconds, they stop. And what's normal is to see no abnormal or no eye movements at all. And with her, what we're seeing is what's called left beat nystagmus. So her eye is deviating to the right slowly and then coming back quickly to the left. And left beat nystagmus is specific to a left vestibular cerebellum injury. This is a central-based injury. This is not a dislodged crystal or anything like that. This is a brain injury. This is a brain injury to the cerebellum, and it's very significant. It's very clear. You can see the powerful beats of nystagmus that last for a period of time, and she has, symptoms of dizziness and movement that are consistent with when we did the declines test and we brought her head up, and we did the Dix-Hallpike maneuver and brought her up, that she was moving around. So motion and movement are going to completely fatigue her brain, and you notice that once she became dizzy, I had her stare at a target. So if you're ever dealing with a person who's dizzy, if you can find out which way they're spinning, you can just have them visualize spinning to the opposite side, and that can stop the dizziness. Or you can just have them think about, focus on fixating on a target with their eyes, and that will suppress that vestibular response and allow them to get more stable. So those are some good things that you can do with your patients that have any type of specific patterns of dizziness. I want you to hyperventilate, like 10 seconds. That's good. Okay. So the hyperventilation test, you have a patient basically hyperventilate for a period of time, and then you want to see if any type of nystagmus starts to develop. You'll see these with metabolic diseases and tumors sometimes that affect the brain, and her results are normal. Take a look at that. Ready? That bother you?
Yeah.
Okay, so keep like the other way. How's that?
Not as bad.
Right. The first way is the opposite of how you're spinning. So if you're in a crowded place,
yeah, that's what happened. Yeah.
And then your anxiety fires up.
Yeah.
Because your body feels like it's falling. So we could see when we did the testing. So that's a cerebellum injury. You also have frontal lobe injury. That accident you had may be more severe than you realize.
I guess so.
Yeah, that might be why your focus attention issues are there. That could also be why you have to get a lot of sleep, so your brain is fully rested, so you don't have anxiety that day. Sometimes these are neurochemical things, but this is definitely like a brain injury. So we'll have to figure out how to coordinate MRI. Some of the stuff we can't distinguish if it's coming from your spine or from your brain or your frontal lobe. It's nothing like you need to be super worried about. Or
No, I know.
It's not like a red flag.
But it's just something that I should probably...
It starts to explain why you're having
all these issues, yeah.
Right? Because one of the things we always have to distinguish is how much of this is functional medicine, nutritional, and I got to balance out your neurochemistry, and I got to balance out your hormones, and how much of it is just like an injury to the brain.
Right.
So it's pretty clear there's an injury.
And nobody ever has, I've never been told that this has...
We need a really thorough exam. You probably just haven't had a really thorough exam.
No.
Okay. So we'll put together things, but I just want you to understand what's happening. So just realize you're going to be extremely sensitive to motion of anything where you feel it's going to the left or the environment's going to the right. Right? So if I go like this, moving it to your right. Right? You don't like that, right? Or out the other way.
Yeah. I mean, I don't like both ways.
Yeah.
But I probably don't like this way more.
Right.
Now I'm a bit tired, so I can't decipher. All of it seems...
It's like your brain's done.
Yeah, my brain is starting to.
So you can see with here, I just stimulate movement to the left and to the right in circular motions, and it really causes her some fatigue. And this is what you see with injuries to the cerebellum, to the vestibular system. And she has a more prominent injury to the left side. So if she's moving to the left and the environment's moving to the right, everything will be much worse. So for her, being in crowded environments can absolutely fatigue her brain, and it can then also lead to muscle tone imbalances, and it can throw off her spine. The cerebellum is involved with the vestibulospinal tract, intrinsic spinal muscles. She can get compensations where her TFL's muscles try to stabilize her, and there we go. There's her chronic pain pattern. And it's also likely that her tarsal tunnel syndromes are part of this dystonic muscle tone that's associated with these brain fatigue patterns and these injuries that she has. So, most people, if you put like a tuning fork in front of them and turn to the left, turn to the right a few rotations, they're not going to have fatigue of the brain and symptoms. So again, this is a classic example of someone who's got a brain injury, and 20 years later that microglial priming causes those patterns. Now, this is the strong indication that she could have some chronic traumatic encephalopathy patterns down the road, and there's also the possibility that she may express into Parkinsonianism with her family history and genes in the next 5 to 10 years. So we got some serious things to address here. You hear that?
Yeah, I hear it. Yeah.
Same?
Yeah.
Okay. Does that bother you?
It's a bit annoying. And this side, for sure, it's annoying.
And if I do this, watch. Is it worse?
Yeah.
It's worse?
That's, yeah.
Aggravated?
Yeah.
Stare at your thumb. Okay.
Wow, I'm tired. It's remarkable how tired I
Is that better?
am. Yeah.
So just staring at something else that calms everything down.
Yeah.
So when you get into a crowded place,
Just look at my thumb.
Yeah, so that suppresses your vestibulocular reflex.
I just leave that location at that time.
You should, but if you can't,
Yeah.
stare at something. Or if you're in a car.
Now, it always happens like in a shopping mall or in a crowded place. I don't like shopping malls, so I don't go to shopping malls.
So what I'm illustrating here is how motion and movement fatigue her brain, and when her brain is fatigued, she's much, much more sensitive to sound. So sound and light are sensory pathways that activate the mesencephalic reticular formation. That's your fight or flight region of your brain stem. And this is done because if something's moving quickly into your visual field or something's very loud, you can immediately activate your sympathetic system and get away. With people that have vestibular disorders, the vestibular system also fires into this area when you're falling. And here you can see with her just some rotations and movements cause her sensitivity and irritability and anxiety to get much worse. And then once we have her visually fixate and calm down those reflexes, it's not as bad. Now, if you look at her chief complaints, her second chief complaint is anxiety, and then followed by forgetfulness, which is happening right in front of us. She's getting brain fatigue and can't even think, can't even focus, can't concentrate, doesn't have executive function. And then hot flashes, irritability, lack of patience. Some of this irritability and lack of patience could just be when her brain is fatigued and exhausted. So we can see that several of her chief complaints were most likely due to impaired brain mitochondria function, impaired endurance, that's then leading to patterns of anxiety, irritability, forgetfulness, and so on.